Hello and welcome everyone. My name is Carla Thorpe. I'm the Director of Prevention and Promotion Initiatives here at the Mental Health Commission of Canada, and it's my pleasure to be hosting this webinar for us this afternoon. So before we get started, we'll just go over a few housekeeping items. The audio for today's webinar is broadcast through your computer speakers, so you can hear us, but we cannot hear you, so you've been automatically muted upon entry into the webinar. We've also made a copy of the presentation deck from today available. So if you see a little area towards the right-hand side of your screen that's labeled Files, you can go on there and download a PDF copy of the presentation slides if you'd like to have a printed copy to follow along with this afternoon. The webinar today is also being recorded, and it will be posted in the webinar archive section of the Mental Health Commission of Canada's website in the next few weeks so that you can view it afterwards or share the link with some of your colleagues as well. And finally, we will be having some time for questions and discussion at the end of the presentation today. So you'll notice there's also a Q&A section where you can send in your questions to us throughout the course of the presentation, and then we'll facilitate a question and answer session at the end of today's webinar. So it's my pleasure today to introduce our guest speakers on the topic of physician mental health and wellness this afternoon. We have four presenters who will be joining us. The first is Dr. Vicky Stergiopoulos, who's a clinical scientist and the physician-in-chief at CAMH. She's also a professor and vice chair of clinical and innovation in the Department of Psychiatry at the University of Toronto. And joining Dr. Stergiopoulos today is Dr. Tanya Tajirian, who's the Chief Medical Information Officer at CAMH and an assistant professor in the Department of Family and Community Medicine. Dr. Trina Wilkie, who's a Deputy Physician-in-Chief, Practice and Professionalism at CAMH and also an assistant professor of psychiatry. And Dr. Javiria Zahir, who's a clinical scientist and an assistant professor of psychiatry, and they're all affiliated with the University of Toronto. So it's our pleasure today to be hosting this group, and we'll turn it over first to Dr. Stergiopoulos to get us started with the presentation.
Thank you, Carla. It's a great pleasure to be here. What we're hoping to accomplish is talk about an area we feel very passionate about, and in the process, first of all, describe the literature on prevalence and factors associated with physician burnout, and then take an opportunity to talk about the work we've done here at our organization on physician engagement and wellness, talk a little bit about the number of initiatives that we have undertaken, and that will be done by Trina. Tanya is going to present the work that is done as Chief Medical Information Officer in optimizing the use of the electronic health record. And last but not least, Zuveria is a suicide expert. And given that physicians have died by suicide more often than the general population, I think it'd be important to highlight the importance of that, keep that in mind, and think of what we can do to prevent those deaths. So I'll get started with how we got started here, which was by reviewing the literature. And our own work was also inspired by tragedies that we had here at CAMH at the Center for Addiction and Mental Health, with a few physician deaths happening several years ago, that helped us put our heads around what can we do to increase wellness among our physician colleagues. And then in the last 2 years, we've seen an explosion of the literature on physician burnout. It's not a CAMH or Canadian phenomenon. It's an international problem, and the burnout rates have been quite high across medical specialists internationally. The Canadian Medical Association completed the National Physician Health Survey in 2017 that identified that more than a quarter of physicians report high levels of burnout, and 1 in 3 screen positive for depression. And when we are trying to put our heads around burnout and what it means, burnout is a syndrome. It includes feelings of depersonalization, emotional exhaustion, and a sense of low personal accomplishment. It's not just limited to those in a full-time practice, but it's also prevalent among trainees, and about up to 50% of resident physicians in the U.S. experience burnout. What should we care? And I think it is quite obvious. First of all, I'll begin with the personal and quality of care implications of burnout. On the personal level, the affected physicians can have trouble sleeping, they have problems with relationships, they have poor mental health, and of course are at higher risk as a result for suicide. And burnout has also been associated with substance use as a means of coping. But beyond the individual affected, the workplace is affected. Affected physicians can lose empathy towards their patients, patients toward their colleagues. We can see professionalism being affected, team dynamics, job satisfaction, premature retirement, and medical errors and the quality of medical care. These are all impacted. And that's another way of seeing it in pictures, but I won't stay at this slide because it touches on the very same things at a glance. Beyond the personal and workplace costs associated with burnout, there are economic costs associated with it. And in Canada, some studies have suggested that the annual costs related to physician burnout exceed $200 million per year. And this is a tiny fraction of what's spent in the U.S., where the costs approximate $5 billion per year. And again, when we're talking about physician wellness, about physician mental health, burnout is not the only consideration, but it has been viewed as a key driver for wellness strategies. What are the factors associated with burnout? The literature points to a few that I've tried to summarize. Work overload. Some complain of long hours, doing more with less. More time in front of electronic health records and less time spent on direct patient care. Others make reference to organizational culture and commitment. Sometimes they perceive a culture of blame that may be hard to work with, lack of support from their administrators, control over their work, and then participation in decision-making have all been described as associated with burnout. Another thing that came to the forefront as we were reviewing the literature was that sometimes there are many barriers to recognizing burnout, both on the individual and the organizational level. Sometimes at the physician level, there may be reluctance to cut down on work, even if somebody is exhausted, because for fear of income loss. Physicians are not salaried. They're billed for the most part in Canada. They bill their provincial services for their work, and they fear that doing less, that means to the lower income. But there's also, within the culture of medicine, this perspective of immunity, that physicians don't get sick, are not allowed to get sick. They're supposed to always show up and do what they can to help others. And last but not least, you can look also at the stigma associated with mental health problems and illnesses, and and any burnout or mental health problems are seen as weakness to cope, and so people are less likely to acknowledge them or do anything about them. But this is where we are today, and the conversation is changing. And again, just to highlight that burnout most often is not caused by a single event, but it's rather a number of small events that accumulate over the time to cause physicians and other clinicians, because other clinicians are affected just as much, to lose the joy of work. Now, how do we shift the conversation from burnout to well-being? And again, the literature talks about focusing on three areas, not only improving the efficiency of practice and maintaining excellence in the profession, but also infusing a culture of wellness and building personal resilience. The thinking was that working on all three can create an environment where individuals can rediscover the joy of medicine. What is resilience? For those that have a background in mental health, I don't think we need to explain, but I thought we'd include nonetheless. Resilience is the ability to bounce back, the ability to have the flexibility enough to adapt during adversity, during stress, bending rather than breaking. And several strategies described in the literature have been developed to build and support resilience and well-being. Again, when we looked at the literature, we saw several initiatives described. Most of them were at the individual physician level and included awareness raising, proactive engagement, teaching or promoting resilience, mindfulness, CBT, often web-based, and then developing opportunities to come together at work and social or other professional development opportunities. The last but not least thing we were able to extract from the literature was that it's important for physicians to have ownership of wellness strategies intended towards them. And it's important to engage them early, to communicate early. It's important to foster formal and informal gatherings, to encourage peer-led activities and support, and for the executive of the organization to provide their involvement and support throughout. And this was the beginning of our work here at CAMH. I'll pass it on to Trina that will describe how the workplace standards in mental health by the Mental Health Commission of Canada help inform our own strategy.
Thank you, Vicky. So I'm going to provide an overview of the process by which we have initiated and implemented some physician wellness initiatives here at CAMH. CAMH is the largest mental health and addictions hospital in Canada, with 3 main sites and over 30 affiliated locations. We have over 400 physicians at CAMH, and I would also note that it's a teaching hospital with high availability of specialist care, and so often with a high degree of complexity. We also have an electronic health record and have undergone significant transformation in the past several years in moving to a paper-free environment, and building also new parts of the hospital, all of which have been part of an environment that has been undergoing significant change. In about 2017, we underwent the development of a physician wellness and engagement strategy. So as Vicky had mentioned, this was based on a review of the workplace standards from the Mental Health Commission of Canada, and focused on both individual, team, and organizational strategies. And along with this was the development of a physician engagement, wellness, and excellence working group. So involving interested physicians from across the hospital in all divisions to both attempt to identify some specific initiatives to work on, and also through these individual team and organizational strategies. That committee, the Physician Engagement and Wellness Committee, undertook a survey of CAMH physicians, so there was a response rate of approximately 46%. And we also used the modified Maslach burnout inventory. And approximately 21% of the physicians at CAMH indicated that they were experiencing burnout a few times a week, and about 50% experiencing burnout a few times a month. So clearly something that resonated at our hospital, but really in line very much with the incidences that were identified at other institutions. We were also looking at who physicians were turning to for support and also who they wanted support from, and both of which was primarily a physician colleague. And so once again, led us to consider the role that the organization had in supporting physicians in a formal way. Some themes emerged from that survey of CAMH physicians, which are indicated here. The importance of developing a culture of safety and well-being. Also having clear leadership, accountability, and communication with physicians. And also, once again, the development of formal processes to support well-being. I would start by indicating that we took an approach of appreciative inquiry to the development of these initiatives. So that is a very deliberate approach, focusing on the desired state. So not focusing on getting rid of, if you will, physician burnout, but rather supporting physician wellness and really looking at the organizational structures and transforming the system to be able to support some of these initiatives. And these were our three primary goals. The first were to address some of the contributors to physician burnout, some of which Vicky has alluded to, and also to promote both engagement in those initiatives and professional success, and to really focus on attempting to engage physicians around the joy of medicine. And so I'm going to talk briefly about the 6 pillars of these initiatives. Some of them were developed organically from the working group and from hearing from physicians, and some also from some of the initiatives that are described in the literature. And that is a peer support program, initiatives to promote professionalism, developing mentorship opportunities, communities of practice, so opportunities for physicians to get together, training to enhance professional advancement, and also promoting the use of information technology. And so I'm briefly going to outline these resulting initiatives. The peer support program was developed based on a model out of Brigham and Women's Hospital, as well as collaboration with the Physician Health Program through the OMA. The idea being that either through self-referral or referral from a colleague, that there would be a matching process from an identified physician and a peer supporter, which would lead to a peer support conversation, which really is trying to reach out to a physician colleague and offer support in a time where that colleague may have been involved in a circumstance which may have been distressing. And really, it's an opportunity to promote connection so that physicians don't feel isolated in what can be a very intense working environment on a day-to-day basis. To this point, there are about 20 physicians who have been identified as peer supporters and undergoing training in order to provide peer support to colleagues. We also wanted to focus in terms of one of the initiatives on promoting professionalism. knowing that professionalism can be impacted by physicians who are experiencing burnout, but also that an environment in which people are experiencing bullying or harassment can be an environment which can also lead to an individual to experience physician burnout. And so within this initiative, we've focused on the onboarding process as a time to establish both behavioral norms in the institution and also to try to develop a culture that supports individuals being open to feedback, being able to provide feedback, and also a process to identify and investigate any specific issues of unprofessional behavior. Thirdly, was the development of a mentoring program. So recognizing that effective mentorship has been associated with many positive outcomes, including both academic productivity, physician retention, and also the ability for people to connect with colleagues. So this program has been working on facilitating pairings, usually between more junior and senior colleagues through a number of different pathways. And at this point, over 60 physicians have agreed to be mentors. I would mention that mentors were nominated by leaders in their divisions, so individuals who were identified as being able to provide support to colleagues in a number of different personal and professional areas. One thing we heard over and over were physicians wanting opportunities to come together, both in person and also virtually. And this has led to the creation of a number of communities of practice. So having groups of physicians gather to discuss their areas of interest. And these are some that are listed here. Junior faculty clubs, so these are early career physicians in the first 3 years of practice. And the photograph here is one of those groups or get-togethers with early career physicians. There's also been the development of a community of practice for late career physicians. So these are physicians over the age of 55. Also women in psychiatry. And queer in psychiatry is a community of practice developed in alignment with the University of Toronto for psychiatrists and learners in the LGBTQ2 community. And there's also been a development of a community of practice for international medical graduates, again, who have some specific interests, both personal in terms of coming to CAMH, to a new province, to a new country, and also some specific professional needs. Fifthly, the goal with some of these initiatives around advancement and training were to promote professional opportunities and career satisfaction. And really there's been 3 trajectories in these initiatives. The development of online and in-person courses for all physicians, but specifically for individuals who identify themselves as emerging leaders. The development of a curriculum for medical heads, so these are local leaders in their divisions. And also to have available group learning for institutional leaders on topics such as giving feedback, managing change, and conflict resolution. And finally, the last initiative was looking at promoting the use of information technology to enhance the efficiency of practice, specifically focused around our electronic health record. And in that vein, I'll turn it over to Tanya to speak more specifically about this.
Hi everyone, my name is Tanya Tejirian and I'm going to be discussing the role of EMRs, and I'm going to use the word EMR and EHRs interchangeably, so it's electronic medical records or electronic health records. So the role of EHRs with physician burnout. I think the hottest topic now in the literature and all of the media has been and is the role of EHRs. It all started with good effort. 10 years ago, 1 physician out of 10 were using EHRs in their daily practice. 10 years later, we have moved into 9 out of 10 physicians are using EMRs in their daily practice. So the plan for EHRs was our ability as physicians to provide fast access to patient information. It's supposed to be the source of truth, EMRs. It's supposed to support our clinical decision-making by our ability to have the most important information of our patients. It's also supposed to support the patient journey through the transitions of care. And most importantly, it is to improve the patient's safety and quality of care. But where are we now, 10 years later? Unfortunately, it became a large clinical administrative burden for physicians. We developed the concept of desktop medicine. So for every 1 hour direct patient interactions we're having, we're spending roughly 2 hours documenting in the EMRs. Physicians feel that we became data entry clerks, so the concept of digital storage. And all of this is impacting our physicians' burnout rates and the concept of joy of medicine. I think most of us know that we've gone into medicine to interact with our colleagues, with our patients, and we're spending too much time in the EMRs. I like this photo because it kind of shows that the mouse has become a part of our medical practice on a daily basis. So what are the drawbacks of health information technology? How does health information technology contribute to the physician's cognitive burden? Unfortunately, all of us know there has been an explosion of the amount of clinical data that physicians have to deal with on a daily basis. So the information the complexity has increased, but unfortunately, the physician's working memory hasn't. All of this is causing possibility of increased errors, adverse events, higher rates of burnout, and higher physician turnover. This slide kind of simplifies a lot of what the literature is also saying. So what are the causes of cognitive burden of our EMRs? The amount of alerts physicians are bombarded with on a daily basis, the click burden. So it is expected that roughly an emergency physician over a 10-hour shift, they will be inputting about 4,000 clicks. The ability to retrieve the information quickly and safely is becoming difficult with the EMRs. And most importantly, our ability to communicate with the circle of care is not optimal. So what are the symptoms of cognitive overload in physicians? One of them is alert fatigue, and quite frequently many of us are not even noticing that we are noticing the alerts that we're getting in our EMRs. Our decreased ability to multitask, and also the physician's reluctance to adopt any new technologies just because of the concept of one more technology that's not going to benefit my patients. So what are the potential solutions for the drawbacks of health information technology? Most importantly, we must invest in developing intelligent workflows, having more user-friendly interfaces. The concept of interoperability, basically the ability of us sharing data between us, the patients, and the circle of care. The power of predictive analytics, so moving from the data entry clerks to ability to actually provide better patient care, and the concept of artificial intelligence, machine learning, and providing precision medicine. At CAMH, we're investing in top 3 strategies to reduce the MR-related burnout for our physicians. They are highlighted in 3 different buckets. One, how do we increase our physicians' efficiency? The second part is how do we increase proficiency? And finally, how do we improve our communication strategy? So in the bucket of increasing efficiency, it is very critical that we allow physicians for workflows and order sets to be personalized, investing in speech recognition strategies such as Dragon, investing in mobile solutions so physicians are not reliant on their desktop to provide their medical care. The concept of getting rid of the minutia, the pebbles in your shoes or the stupid things. And most importantly, the ability to evaluate and monitor the data and identify top users of your EMR and asking them for tips and tricks. In the bucket of increasing proficiency, most importantly is providing the flexible training. It's not enough to provide your physicians with onboarding training, but what about later on when things are changing in the EMR? So having that accessibility for getting the physicians up to date with any changes of the EMRs is critical. Promoting documentation best practices. How do we reduce the EMR's note bloat? And again, how are you able to find the most relevant information very quickly is critical. And the concept of pajama time. How can we reduce our physicians after hours EMR use is very critical. And then developing initiatives. We have the SWAT team, which is based on the SPRINT team that Colorado Health has provided for all of their clinics. And basically it is the concept of re-education in their EMRs and providing fixes for issues that physicians are having. And finally, at CAMH, we are developing monthly newsletters to communicate regarding any of the changes we're having with our EMR, understanding that, physicians are having way too many emails, so how do we reduce the email fatigue? And we're also developing physician think tanks. Think of physician think tanks as hubs of creativity, ideas that come from different divisions to reduce the EMR-related burnout. And the best slogan that my understanding resonates with a lot of physicians, how do we move from data-rich EMRs to data-driven? I think the key for getting physicians on board with EMRs is the next step. And I truly believe better physician experiences means better patient outcomes. Class Arch Collaborative is an organization that investigates and researches health information technology impacts on physicians. And for them, the three concepts of certain institutions have less burnout regarding their EMRs of three things. One, providing that ability for their physicians for personalization. The second one is ongoing education. And the third part is a culture, developing a culture of IT in an institution that's highly responsive for physicians' need. It's critical for increasing EMR satisfaction.
Thank you so much, Dr. Jirian. My name is Dr. Javeria Zahir, and I'll be speaking today about a very important topic, physician suicide. I think most people who are on this call have lost a colleague to suicide. Certainly many institutions have grappled with physician suicide loss. Today we'd like to talk about what we know about risk for suicide in physicians. How do we know what the root causes are? Are the risk factors similar for physicians than they are for the general population? And if there are some differences, how can we better understand how our medical culture can contribute to risk for death? And the most important question, I think, and a source of hope is what can we do to help, whether we are individuals or organizations or communities or cultures. So our first question is, what do we know about the risk for suicide in physicians? I think many people would assume that physicians would be at lower risk for suicide than the general population. Paradoxically, physicians have healthier lifestyles, they have higher socioeconomic status, they have access to care, but suicide rates are actually higher among physicians than they are than in the general population. About one physician per day in the United States dies by suicide, 300 to 400 per year. For men who are in North America 3 times more likely to die by suicide than women, the rate is significantly elevated, 1.4 times in the general population. But for women who are classically at lower risk for suicide, the rate is more than double for female physicians than those in the general population. Increasing suicidal ideation begins early. It begins in medical school. It persists in residency training and beyond. Similar to the data that Dr. Stergiopoulos described earlier, meta-analyses show that about a quarter of medical students have had suicidal thoughts in the last year, and nearly 1 in 3 resident physicians would meet criteria for major depressive disorder. So how can we understand the root causes and the risk for suicide in physicians? We need to start by knowing about suicide in general. Death by suicide is a tragedy that not only affects those who die, but their families and friends and communities. It's so important for us to talk about issues of wellness and burnout while also remembering that suicide is a complex outcome, biological, social, psychological, and cultural underpinnings. And if I think we could remember one thing from these slides today pertaining to physician suicide, I'd really like to stress that experiencing suicidal thoughts or engaging in behavior not only increases someone's risk for death by suicide, but these experiences in and of themselves are distressing and debilitating, and they're a sign that somebody is suffering and they deserve to get help. For physicians specifically, risk factors for suicidal behavior or death by suicide are similar in many ways to those of the general population.
For example, a previous history of suicidal behavior, a family history of suicide, depressive symptoms, or substance use. However, there are also factors that are specific to physicians which may explain the higher rates of suicidal ideation and behavior in this population. And understanding these specific factors could help us develop targeted prevention strategies. I'm going to present a quote now from Michael Myers, Dr. Michael Myers, who is an expert in physician health at SUNY Downstate Medical Center in Brooklyn, New York. In an opinion piece in BMJ, he says, physicians take their own lives when many diverse and overwhelming forces come together all at once, a perfect storm of biopsychosocial factors. There's no one reason why a physician might die by suicide, and many factors may be at play. It is important that we are aware of these factors and understand them so we can try to support our colleagues. I think the point that that Dr. Myers is demonstrating really beautifully is that we can't understand physician suicide by focusing only on depression or substance use. We also have to consider other factors like burnout and wellness, as well as difficulties in accessing care. So we'll go through each of the different buckets of factors and describe how they may apply differently to physicians. Physicians may have a higher rate of prevalence of depression than non-physicians, as we described earlier. There's also a higher frequency of alcoholism and other mental health conditions in female physicians than women in the general population. There are higher rates of substance use in certain specialties, which could be based on personality or exposure to these substances. And many physicians would describe sleep disturbance, being on call, being up long hours, interrupted sleep. In terms of psychological factors, I'll present to you a quote from the New England Journal of Medicine from 2005. This is a really seminal article about physician suicide. It's been noted that physicians tend to neglect their own need for psychiatric, emotional, or medical help and are more critical than most people of both other than themselves. They are more likely to blame themselves for their own illnesses, and they are apparently more susceptible to depression caused by adverse life events, such as the death of a relative, divorce, or the loss of a job. Physicians tend to be a high-achieving group. They tend to be empathic, they tend to be perfectionistic, and they tend to be quite vulnerable to shame, whether it's in our training or in our practice. And I think this quote gets at those pieces. In terms of social and cultural factors, and I mean here cultural factors, factors specific to the medical culture, social isolation and disturbances of social networks related to scheduling and professional identity. So you're going to be missing, for some surgeons, a third of special events. If you're a two-physician family, you may not be seeing each other very often if people are on different schedules. Experiences of trauma, bullying, specifically gender harassment, as well as burnout. Regulatory complaints are associated with increased rates of suicidal ideation, and this has been shown in several studies from the UK and some studies in the US. Access to and choice of lethal means for suicide. And finally, physicians who took their lives were less likely to be receiving mental health care treatment compared with non-physicians who took their lives, even though depression was found to be a significant risk factor in both groups. So this is really interesting because physicians have access to finances, they have access to the highest quality of care, they know what evidence-based medicine is, but for some reason they're less likely to seek care. They certainly concerns about stigma, lack of time, lack of access, as well as the burdens of confidentiality. What is it like to go to somebody who you consider to be a colleague? Fear of discrimination in licensing and applications for hospital privileges. And some specialties have a higher risk for suicide than others, specifically psychiatry and anesthesiology. What can we do to help? I think in general in suicide prevention, we want to be looking at evidence-based strategies, but it can be challenging because it's such a rare multifactorial outcome rather than simply just a consequence of mental illness. Overall, there's very good evidence for restricting access to lethal means that can prevent suicide, whether that's as an environment, as a country or a province, bridge barriers, decreasing access to over-the-counter medications, in other cultures, locking up pesticides, gun control. Interestingly, young people tend to be very responsive to interventions like gatekeeper education or anti-stigma initiatives, so school-based programs work quite well. Certainly pharmacological and psychological treatment of depression, as well as anti-suicidal effect of certain medications, and physician education in primary care. We have promising evidence for some interventions, including gatekeeper training. So for example, in a medical setting, that might mean training mentors or training people in positions of power to be able to recognize the signs and symptoms of depression or risk for suicide, media regulation, internet-based interventions and helplines, which could be useful for physicians who may have challenging schedules or may have concerns about confidentiality, screening in primary care, and ketamine. But for physicians specifically, there's a lack of evidence specific to this group, which makes sense because it's an area that's sort of burgeoning in the last few years, but it's a small population. But we can think about the evidence for suicide prevention as well as the evidence that we understand about wellness, burnout, access to care. So the first step is raising awareness and addressing stigma. We need to support access to high-quality mental health care while addressing fear of consequences. We need structural and systematic approaches, identification and support for those at risk, humane training and working conditions, and support through college and legal issues. I have a quote here from a podcast about physicians and suicide. I have so much gratitude to all the people in my life who said, sorry guys, I can't come to this meeting tonight. I have to see my therapist. That normalized it for me. And I'm going to leave you with a couple of suggested reading and listening. We have an article here by Rebecca Black, who is a physician who lost her partner to suicide, as well as a really lovely podcast featuring a doctor, Dr. Michelle Marlborough, who has lived through and recovered from suicidal behavior. I'm going to leave the last word to Dr. Marlborough, who said, we need to look after each other. We need to speak up. We need to address what maintains illness and what may prevent our peers from seeking help. Thanks very much.
And I think we are ready for your questions.
That's wonderful. Thank you so much, Vicky, Trina, Tanya, and Javiria for your presentation. So we're going to open it up now. If people have some questions, you can type them into the Q&A feature, and we'll be able to see those questions, and then we can we'll review some that are similar so that we're only asking the question once. But we should have about 15 minutes for questions. So I'd invite you to enter those now into the Q&A box. And maybe, Javiria, I'll ask you one question just when we're getting started for people to input their answers. But there was a documentary that we had the opportunity to screen at the American Association for Suicidology conference that focused on suicide rates among residents and interns, primarily in the U.S. It was called Do No Harm. And you've touched on a number of the items that they were surfacing in that documentary, particularly around the issue of people fearing to come forward because they're concerned about, potentially losing their license or losing their jobs when they have like a heavy student debt to pay off, and also how the student debts keep them sort of in the profession even when they may want to exit the profession. So I'm just wondering if you can comment on some strategies maybe that you're looking at to mitigate some of the concerns that physicians, particularly those early in their career, may have about coming forward.
I think that's a really excellent question, and I think the issue around debt, and especially student debt, dovetails really nicely with the piece that physicians are largely independent contractors, and so as we mentioned earlier, if you don't work, you don't get paid, and how do you recoup so much sunk opportunity cost? I think I don't have a very good answer for this. I think this is something that we need to start thinking about culturally and societally. There are some people who are discussing options like loan forgiveness or mental health support. I think we also really need to address a really important issue, and that is if you disclose these issues when you're trying to get insurance as a learner, that could have negative consequences for you upstream, and you might not be able to get coverage for mental health conditions later. So I think we need, these are really big questions and really important ones, and an area for further study.
Okay, thanks, Javiria, for that. I think we've got one more question that's come in. I'm just going to review it here quickly. So I guess, Vicky, I think this was in your portion of the presentation when you were, or it might have actually been Trina's, when you were talking about training that you're providing to physicians who have been selected or volunteered to be peer supporter. So I'm wondering if that's, the question is about sort of what kind of training you're providing. Is that something that you're doing in-house, or is that something that you've contracted out or brought in a specific course to train the peer supporters?
Yeah, I think Trina can speak to that, and I'll add if needed.
Yes, so the training is being done from the director from the Center for Peer Support and Professionalism from Brigham and Women's Hospital. So we did bring someone in external in order to do that training. We do anticipate, however, over time that there will be, that this training will not sort of be a one-off, that it will likely be on multiple occasions, and our hope is that some of that can be done in-house.
Jo Shapiro is our trainer. She's already come to CAMH once, and she's actually coming back next week. And the idea is to develop a train-the-trainer model, so she will do the training this time, but we will be developing our own capacity to continue providing that.
Okay, that's great. Thank you both. And I know you mentioned in your presentation that it seems like you've had a fairly significant number of physicians who have volunteered to play that role of a peer supporter. I'm wondering if you could comment a little bit on sort of, did you need to do a lot of work given that a lot of stigma still exists around mental health? How were you effective, I guess, in encouraging physicians to step forward into those roles?
So I think both for the peer supporters and the mentors, they were individuals who were identified by their division leaders, so by their chiefs, as people who would be likely to, first of all, want to engage in that role and also to be successful in that role. And I have to say that when we reached out to both the peer supporters and the mentors, there was a very strong response that people wanted to be involved and wanted to be engaged in such a program. So at least to this point, there was certainly not an issue when people were approached about these various roles.
And again, it ties, I think, to the one of the key ingredients that we identified in the past, that physicians need to be co-producing the strategy that's focused on their wellness. And these suggestions came from the physicians, so it wasn't as difficult to get champions because the suggestions came from them.
That's great. Thanks, Vicky. And I'm sure that the fact that you've got a nomination process then is a good incentive, I guess, as them, you're approaching them as someone who's, stood out in terms of someone who would be a good candidate for this kind of a role. There's another question.
Actually,
it is, yeah, and it's great to be positioned that way. There's another question that came in as well about preventative work that you might be able to do during med school, and I know that that's when you said you're starting to already see higher rates of suicidal ideation for those that are still in med school. I'm wondering if you have any thoughts on what more could be done in terms of prevention.
I will start, and then Sverre will provide, of course, more specifics that are based on evidence. But I'll tell you some of the work that we're doing here at the University of Toronto. Because, again, medical student wellness is not necessarily a hospital responsibility and accountability. It's more of a university one. There was actually a death by suicide of a medical student this past year. In addition to a death of another student that happened in the last 6 months. So we are working with the University of Toronto to identify how best to enhance their services, including a step care model, similar to the ones that the Commission is familiar with and has promoted. From access to online internet-based cognitive behavioral therapy, to having timely access to health supports, to access to specialized comprehensive services as needed. The discussions with the university are just beginning, but I anticipate that we will continue to support the development of comprehensive supports for University of Toronto student health, and that includes medical students. Now, medical students, of course, have access to also supports through the University of Toronto already. They have access to clinicians that can support them during periods of stress. And they have access to mentors, advisors, and access to accessibility, so that they can have accommodations if there is something not quite right, so they can be supported to complete their training. I don't know if you want to talk a little bit specifically about suicide, if you're familiar, aware of any initiatives.
So I think for medical students in particular, they are, although there's a variety of ages and backgrounds in any class, they are a younger group of people, which potentially suggests that they may be responsive to interventions that work with young people. For example, anti-stigma initiatives, gatekeeper education. I think, as Dr. Stergiopoulos mentioned, we really need to hit the basics, and that's access to high-quality mental health care. I think when you speak with students, whether it's individually or you look at the literature, the qualitative literature, people sometimes get really anxious about individual solutions. So you need to be more resilient, you need to take yoga, you need to take a mental health day, and I think a lot of our students are advocating, just as staff psychiatrists are, for those broader sort of cultural or structural solutions as well.
A really great point. And actually, we have a couple of people who have written in questions on that theme about access to mental health services, therapy, and counseling. And I'm wondering if that's a barrier to the group that you're trying to reach, either in med school or once they're physicians. Are there some barriers to them accessing mental health services? Because I know you talked about stigma, but I'm wondering too whether there are financial barriers there as well, or whether or not they have access to those services.
There are no financial barriers to my knowledge. The barriers would be work-related, finding the time to get help, the culture of invulnerability that is not happening to me, or self-stigma. They see it as a personal weakness. And in general, yes, it is hard to access mental health services, but it's not the financial reasons. It's all the other reasons that lack of easy access to high-quality evidence-based mental health services. Having said that, many of the universities have health services on site. They do have some counseling on site. Our organization, for resident trainees, we do have psychologists that are hired externally from an organization, so they're not employees of our organization, but they can provide time-limited but evidence-based counseling therapy to individuals, physicians and non-physicians, to anybody who is having challenges within our organization. Then the professional organizations like the Ontario Medical Association, for example, all provincial organizations have physician health programs that the physicians can access. These are all OHIP-covered services.
So that's similar to what traditional workplaces might have in terms of an employee assistance program, but it's delivered through the medical association. Is that right?
Yes.
Okay. So we have a lot of interest in what you're doing around peer support. There's another question that's come in that regard about whether or not individuals do any kind of screening before they're accepted as a peer supporter after they've been nominated.
No, at this point there's no formal screening process. They're nominated. There's a conversation with our physician lead with regard to the peer support program, and then we're engaging them in training. So at this point there's no other formal screening apart from their nomination and interest.
The nomination itself is a process of screening because their chief, the physician leader in their area, wouldn't nominate somebody who is not sensible, sensitive, trustworthy to maintain full confidentiality. So it happens at that level.
Yeah, and presumably after they've undergone the training as well, there would be an opportunity for people to opt out of proceeding as a peer supporter if they had any hesitation, I guess, in terms of moving into that kind of a role.
Oh, absolutely. They're not forced to take that role, just to be clear. These are individuals that are handpicked and agree to take on that role. And naturally, feedback after they have an opportunity to provide peer support, feedback from themselves and those that are supported will be instrumental on how we best support both our faculty and the peers themselves.
Yeah, I was just about to ask you about that, whether or not they have sort of a mentor when they're first starting doing the peer support sessions, or how they're getting feedback to help shape how they offer that moving forward.
I think we have a physician lead, Susan Quennell, who is leading this part of the initiative, and she is the one organizing them. She is going to be the one perhaps bringing them together after the training periodically, and together, again, it is a model of co-production. They'll work together to identify what they need to feel supported from us.
Great, thanks, Vicky. So we'll just give people a moment. If you have any final questions that you'd like to enter, we've got a few minutes left before we need to wrap up, so we'd encourage you to submit those now if you can.
And I just wanted to highlight some things that we have not particularly discussed, but are, I think, instrumental in any physician wellness strategy. We have an annual review of our physicians, and the review is intended to also review their wellness and proactively go over areas where they may require support. That, along with defining roles, having role clarity, and shifting the culture of the organization from a culture of blame when a mistake happens to a culture of learning. These are all kind of additional key ingredients to achieve wellness for all clinicians.
Okay, thanks, Vicky. We have a couple more questions that have come in around on the topic of sort of curriculum for medical students. I'm wondering if there sort of what plans, if any, or I'm not sure how much you can influence the curriculum in medical school, but if there are any plans to address sort of the gap in terms of the amount of training that physicians are getting around mental health, and expanding that in particular beyond a lot of what they might be receiving already, specifically with respect to pharmacology.
I think there is a parallel strategic plan at the University of Toronto Faculty of Medicine. Wellness, diversity, inclusion are an instrumental part of that strategic plan, and they are working to look at the curriculum. It's not our group, but there are people from our organization that are part of that effort that is looking at how to inform the curriculum for medical students and residence trainees for that matter. And again, I can't stress enough the importance of not only having executive support at the organizational level, but to have alignment between organizational goals and university goals. And in this case, we were lucky because there is emerging full alignment. Although we started it 2 years ago now, this year the university strategic plan talks about wellness as a key strategic pillar, and that will definitely inform and influence the curriculum.
That's wonderful. Well, thank you so much, Dr. Stergiopoulos, to yourself and your colleagues, Trina, Tanya, and Javeria. We really appreciate you participating in the webinar this afternoon and sharing all of this information. I know that it's a topic that many people have been concerned about, you know, even at the local level, in terms of being concerned about the amount of pressure and stress that's on their physicians, and, you know, the important work that they do within the community. So I think it's been a very valuable session. So I'll just let everyone know that at the end of the webinar today, as you close the screen, you'll be directed to a very, very brief 10-question short evaluation. If you can kindly take a few moments to complete that, would be very grateful. It really helps us in planning future sessions that we look to host, to get some feedback from you on some of the topics that you might be interested in. And if you're unable to complete the survey immediately today, we will send you a follow-up link to the survey in a thank you email that you'll receive after participating. So thank you again to all our tremendous presenters and to everyone else who was able to join us for the webinar this afternoon, and we really hope you have a great rest of the day.